Our primary thematic area today is the impact of Balochistan Health Card Program on public sector health facilities. The question that we pose is that health insurance is often viewed as a catalyst for the growth of the private sector, but it may not always have the same effect on the public sector health facilities. What, in your view, will be the impact of Balochistan Health Card Program on public sector health facilities? And if any impact, will this impact be positive or negative, given what you know and given what you have learned through this workshop and through your personal experiences? So I would like to start this question from Dr. Imran Masood Durrani.
You didn't give me 3 minutes actually. I needed 3 minutes to answer this question, but let's start. I think when we're talking about private and public sector, I have to tell you that insurance is freedom of choice. Insurance is about freedom of choice, and that is what insurance means. So if you have an insurance, I can choose which hospital I want to go. Do I want to go to the public sector or do I want to go to the private sector? That is one aspect of what I just want to say. But the question which you posed was basically looking at the public sector itself. About a few months ago, I was in Germany with some policy makers, and what I learned from there that the government of Germany just builds hospital and is not responsible for running it. It is being run by the insurance companies. So I think this distinction needs to be really clarified between us in a way that what is private and what is public, because maybe I will be repeating this thing again and again. Who is the doctor in the private sector hospital? It is the same doctor who is sitting in the public sector hospital. This moonlighting effect which you see somehow or the other destroys the division between the public sector hospital and the private sector hospital. Because the same doctor which in the morning is sitting in the public sector hospital, also in the afternoon or later in the day is sitting in the private sector hospital. So I think that is something which we need to consider while defining what is private and what is public.
Thank you, sir. The same question to Mr. Abdullah, if he wants to add his views.
Thank you very much, Dr. Shaku. I just would like to add to what Dr. Saab said a while ago, that the private sector in Pakistan has always depended, rather it has grown upon the public sector. For example, I just would like to narrow it down. Whatever the qualification of a medical practitioner be, they would always like to be, particularly in the teaching cadre of the Department of Health or at the federal level at the Ministry of Health, to be called assistant professor or associate professor and professor. There is a kind of race because there is market behind with this title. And the stand by the government, I recall one of the professors when he got retired, I visited his private hospital here in Quetta city. And I asked if he was very much satisfied with his current position being the MS of his private hospital. He said that was something else, the stamp of the professor or the head of the department. It is actually economics behind, because we are not very much good. In public policy, it is said that the market is always inefficient unless it is properly regulated by a very efficient and effective public policy tool, which we lack in the developing countries, and particularly in the province of Balochistan, that we do not have a proper tool to regulate the market. So this inefficiency of the market that is highly growing upon the resources of the public sector. Anyhow, whatever public sector we do have here in the private sector, there is a kind of demarcation. So we have to be very much vigilant how we are going to this question. I'm just building upon what you have raised. It's very much pertinent for the policy makers, particularly the Department of Health, and then of course the health card program the CEO and the team, they are supposed to provide input to the health department. How the Healthcare Commission is going to regulate it? Because we have to have private sector in real sense. Private sector should be private sector and public sector should be public sector. And then we can have a proper environment in our province. Currently I call, as I said, that market is never efficient, it is always inefficient. And due to this inefficiency, it causes problems. Always the market causes. So the government is supposed to have a very robust and effective regulatory framework, which I believe is the Healthcare Commission. I was very much hasty in getting it formalized and organized. I'm not sure if it is with the same pace going ahead. Unless we have it in place, we do not have a regulatory framework, proper regulatory framework in the province of Balochistan. Then we can have a very proper environment for effective implementation of course, this insurance program.
Thank you, sir. Underscoring the need for a proper regulatory mechanism and clear demarcation between the public and private sectors. So even if such a clear demarcation exists, Dr. Sheraz, could that lead the Balochistan Health Card Program and its initiatives, could it lead to a potential shift in the patients from the public sector hospitals to the private sector hospitals? And if such a shift occurs, how might the quality of care be affected in public sector hospitals?
Well, thank you very much, Dr. Shah, for that question. Every public policy, it creates winners and losers. And in the current instant, the private sector would appear to be the bigger winner than the public sector. If you measure that in terms of earnings. But at the same time, the public sector will get some breathing space. The private sector was thriving because of the failure of the public sector and because of the long queues and waiting times. So if part of the workload is shifted to the private sector, I think the public sector will also be able to stand up to the occasion and serve whatever workload or patient load is there. About the quality of care, we need to understand that healthcare financing is only one of the 4 functions of the health system. And another important function is reputation and stewardship. So expecting that the healthcare financing will do everything including reputation and stewardship, that would be a very, I would say, wrong expectation from a healthcare financing initiative. So I think to summarize my argument, it is that the public and the private sectors both will benefit from this program. In terms of finances, it will be the private sector who will be the biggest winner. But in terms of efficiency, some efficiency will come to the public sector as well. With regards to the quality, that may improve partially due to the financial incentive that you structure, but mostly that will rely on the stewardship function of the healthcare system and not the financing function. Thank you.
So the need for the stewardship function being strengthened within a health system has been underscored, and as pointed out by Dr. Sheraz, such a shift can lead to amelioration of overburdened hospitals in the public sector. Do you want to add to this, Dr. Imran? If such a shift occurs, if the private sector thrives, can the number one, can the public sector compete with the private sector? And number 2, can the public sector, through this competition, be able to retain its human resource from being taken away by the private sector?
Thank you, Dr. Shako. Well, I'll rephrase what my colleague Dr. Imran said. Basically, in context, especially Balochistan, where we see that the very same people that work in the public sector are also the ones that work in the afternoon in those hospitals. So it is not a change of premise, it is just a change of premises and not the person. So in terms of Balochistan, looking into what we have so far done in the last 10 months, I believe that the change, which is obviously positive, be it the private or the public sector, it has not been what we expected, but we are on a better track. Well, looking into the current statistics that we have, I'm sure, inshallah, because in Balochistan what we have done, and this is something that we did in Balochistan based on the experiences that our sister programs in other provinces shared with us, and that is the 100% retention of the utilization of the funds for the public sector hospital. Now the intention was not only to improve the performance of the doctors, but to also give them a token of gratitude through money. As a government servant, I wish that everybody works in the interest of this country as a patriot, or in the interest of this country as a religious person, but the fact of the matter remains that it is always Benjamin again around which the people turn. So you have to create economic avenues for people, and this is what we have done in this program. The second thing is that we also know, and this is also again based on experience, that government servants and government institutions are very prone to status quo. They do not want to break ice, they do not want to break the status quo. And that is why changes are always not felt in the short term, it takes a long term. So, based on those 10 months, I believe we will be able to see the change, that is the improvement in the public sectors, inshallah, after around 2 years. And the reason why I am saying that it might take around 2 years is because in Balochistan we are still in a situation where in a few districts we do not even have proper DHQs. We call them DHQs, but we do not have a single specialist in those hospitals. And in order to make people move to those districts, we have created those economic avenues for them. Now, as Dr. Imran also said, those very people who are working in the public sector in the morning go to those private hospitals. Unfortunately, because the interest of that doctor or that practitioner is equally distributed between his private hospital and his public sector job, that is why in some cases, in some districts, we will see the improvement in the private sector, whereas in some places the improvement will be in the public sector. It will be based, I believe, more on that person's specific interests.
Thank you, sir. Touching upon the incentives attached for public sector hospitals, I would like to throw out two questions to all the panelists, anyone who would feel like answering it. Number one, if we are incentivizing the human resource by giving 30% to doctors, 15% to nurses and paramedics, could this affect the team dynamics and the morale within the public sector hospitals? And maybe the workforce could be more motivated, or maybe it could lead to internal conflict within the workforce. What are your views on that? And secondly, the 40% that we are giving for the hospital's use for maintenance and consumables, will that be enough to significantly improve the infrastructure and resource availability in these hospitals?
I would like to comment on this. I believe I have observed myself when I was serving as Secretary Health. At the SPH, you also referred to the cardiology and cardiosurgery. I saw a kind of change in the behavior of the team members working over there due to this incentive. Prior to that, I know you all know them by name and by designation. There were certain employees, either they were doctors or the paramedics or nurses, they were not very much willing, but after having the health card incentive in place, I found a kind of competition among them. And of course, there is also higher risk of internal conflict due to the formula we already have for, because if the doctor is taking larger share and the paramedics are receiving lower share, it might be a risk. And I think you have already confronted with such questions. As far as the infrastructural development, already the government of Balochistan, because at the moment, parallel we have the mainstream system wherein larger chunk of the public sector resource is diverted towards infrastructural development in the province. If I refer to the development project in particular, the development plan and budget in particular, and also the non-development budget resources, normally they are shifted towards the infrastructural development. That can be in form of developing buildings, roads, or other infrastructures. Also the addition of the human resource, that is another trend in the public sector. So already the hospitals, they are getting funds through the public sector development and plan and all, as well as the non-development plan, wherein the infrastructure improvement is there. This can be a positive addition, because what happens now, generally the budget making is at the provincial level, and the feedback taken from the institutions that can be secondary or tertiary level healthcare facilities, that is very much minimum, almost equal to zero, I believe. So what they require doesn't become part of the development plan. So there are small areas wherein day-to-day expenditure is very much required, and for the complete year they do not have a single penny in the specific head of account, that they are confronted with problems and major activities they get stopped. This addition has helped a lot. Practical, I'm talking with practical perspective, this is not something theoretical, that since we have started supporting the hospitals, particularly the tertiary level facilities in Quetta, day-to-day activities, day-to-day requirements are met through the health card scheme.
Thank you. Would any other panelists like to add to that?
Thank you very much, Dr. Shah and Abdullah Sahab. So, first, I want to quickly go back to your previous question about the public and private sector. So, as a steward of the healthcare system, the Department of Health should be concerned with the overall health system capacities, in which public and private are two parts. So, if through healthcare system, through the health card program, you are adding more beds to the overall capacity of the healthcare system, you are improving. And if your waiting time is decreasing, you as a health system are improving. If the rich can, if the poor can go to the private sector, you are promoting equity. So I think we should rather be concerned overall with the health system level, rather than getting into the dichotomy of the public and private sector, which is already very diffuse, as mentioned by my colleagues. The second thing is, you will come across the allegations that you are privatizing the public sector through this insurance mechanism. And I always counter-argue that no, we are nationalizing the private sector. It is a sector which builds the hospitals with its own money, and we just give them for their services. Now, for instance, you have a state-of-the-art hospital in Balochistan Health. You do not have to put any capital cost into it, but you just pay them for their services. Now, coming to your question about the funding mechanism, we had this hypothesis that in KP we will be able to reduce the funding from the supply side and put more funding on the demand side. But reality will strike you in the face when you find that 80% of your expenditure in public sector is in salaries, and you cannot do anything about it. So it is only the 20% which you can work around or manipulate. And I wouldn't ask for reducing that 20%. I would rather ask that the fund retention formula you have should go 60 or 70% into your infrastructure and quality improvement, equipment and medicine, and 30% into human resource. And that will balance out the lopsided distribution of healthcare financing that we have on the supply side. Thank you.
Thank you. Would anyone like to add?
I would kindly agree and disagree with both the topics, and maybe this will add a flavor to the discussion. When you say that salaries is the biggest issue, then why don't we make, I was working for a university in Islamabad, and we define a base pay for every doctor, and we say extra income which you bring in, your pay increases. We can define that. That shouldn't be a problem. I was working for Health Services Academy under GIZ, and there we define that your basic pay is 100 rupees. If you bring in more research, I can pay you 150 rupees, depending upon the research we bring in. So can we define that in the public sector hospital? But before that, we have to correct the Civil Servants Act. So the issues which we are really thinking is not insurance issues. These are systems issues. And when I think people who are very senior people sitting around here should consider that in the sector reform issues, how to improve that. I think that's one part. Third part, which I just wanted to add, when we give extra income to our public sector hospitals, are we obliterating the efficiencies within the system? Because that people can earn money in the public sector and in the evening then sit in the private sector and earn more money. So I'm just giving thoughts. Maybe I have no solutions to that. I have no solutions to that. But these are just thoughts coming to my mind.
Sir, as government servants, unfortunately this is a reality. We do not try to differentiate between good or bad or that. Taking a decision, we do not only look into the good of it, because I know everybody wants that good. Unfortunately, we are always more focused on doing something bad but not worst. So the situation is like this, and unfortunately, in Balochistan or in the public sector, it is very difficult, as I said, to bring in a change. So perhaps the only the mathematical option of making or inculcating upon the doctor to serve was to increase or ensure that incentive package. Now, इसको मैं आसान अल्फाज में इस तरह कर देता हूँ. For instance, we are spending 10 rupees on something and we know that unfortunately it is not working. But if you pour in another 2 rupees and make that system work, health card at the present is working on that mode. Thank you.
I think health card is very much in the insurance system is in the transition phase. What I envision that a time might come when the policymakers, due to the positive aspects of this very scheme, will start thinking that they should stop further expansion of the existing healthcare infrastructure. I believe, because when people start receiving services through this scheme, and also we find them satisfied with the services they are receiving either at the public sector or the private sector, the policymakers will one day, soon, if we make it a success, they will start thinking that further expansion, because further expansion is a problem. We are building hospitals and we cannot make them functional. This is a big question. So I believe this is also one of the key areas we have to be thinking about.
Thank you, sir. So, do you want to?
Yeah, so last few cents is that in fixing the how do we make a good public-private mix. So as we said, there is a role for stewardship, and if you are saying, for example, if we say that 60% of the additional income is going to the doctors, therefore they will be performing within the public sector hospital. But on the flip side, 100% of it goes to the doctor in the evening or in the private sector. Then that incentive kind of does not produce its desired effect. Then what we can do is to bring in the element of strategic purchasing within the program and to decide what to purchase and where to purchase it. So for instance, we should have a very clear demarcation what the public sector is good at, and a policy decision should be taken that these services will be provided by the public sector. And to decide what the private sector is best and efficient at, and as a policy decision, we shift that workload over there. So I think that incentive might work.
I totally agree. I think we should look at strategic purchasing. In the presentation I was talking what to buy, where to buy, and what volumes to buy. So if the maternal services are better at the public sector, let's buy it from the public sector. Maybe chemotherapy is better in the private sector, let's buy it from there. So yeah, different outcomes.
Thank you. I'm not going to summarize what the panelists have just said, but the discussion has revealed at least 4 points that I can name, or which I think are important, and upon which we can hold 4 more days of panel discussions. But ये जो हमारा जो पहला थीमेटिक एरिया था, impact of Balochistan Health Card Program on the public sector, इसके हवाले से if the audience has any question, please raise your hands. You will be facilitated. And the medium of language can be English or Urdu. You can use either language. इसमें कोई कैद नहीं है.
क्वेश्चन करें, वो खुद क्वेश्चन करें, आप तक पहुंचाएं.
नहीं, क्वेश्चन वो करें, एक आधे मिनट के अंदर करना है, 30 सेकंड.
खुद कर ले, हम समझ जाएंगे. हमें तो चला.
Mohammed Jalaluddin, Zonal Head from the State Electoral Corporation. I have a question. In my opinion, the future of the Balochistan Health Card Program in public sector hospital is not bright. Still, 9 months have been passed. So many reasons we have. I think we have. But the prime one is that the policy of the government towards the public hospital is not accordingly implemented. Due to the reason, still the public hospital is not giving that much facility which we were expected from the public hospital or which are provided by the private hospital.
और जलाल साहब तो रोज इस बारे में बात करते हैं. यू आर वेरी राइट. प्रॉब्लम ये है कि पिछले 10-20 साल से खासकर मैंने नोट किया है कि मतलब हमारे वालिदैन और चाचा में एक सरकारी मुलाजमीन के फैमिली से हूँ, तो छोटी पोस्ट पे रह के उन्होंने जो पावर एंजॉय किया, जो एक्सरसाइज किया, वो आजकल बड़ी पोस्ट पे भी नहीं हो रहे हैं. हमने हेल्थ कार्ड के अंदर मासिवा इनेक्टमेंट के जितने भी कवानीन और जितने भी रूल्स और जितने भी प्रोग्राम्स या जितने भी प्रोसेसेस किए हैं, वो तमाम, मैं मतलब ये कोई फ़ख्र की बात नहीं, बट मैं बड़े उसके साथ कह सकता हूँ कि बाकी किसी सूबे ने नहीं किए. हमने हाईएस्ट फोरम जो एक सूबे की गवर्नमेंट का हो सकता है, दैट इज़ द प्रोविंशियल कैबिनेट. ईच एंड एवरीथिंग वाज टेकन टू दैट, इंक्लूडिंग यूटिलाइजेशन एज वेल एज द मोडेलिटी ऑफ वर्किंग विद स्टेट लाइफ बाय द पब्लिक हॉस्पिटल्स. एमएसएस चूँकि आप कोयटा में आप अगर देख लें, हमारे टर्शरी केयर में हमारे एमएस साहिबान प्री ऑक्यूपाइड होते हैं. दूसरा, यहाँ पे पब्लिक सेक्टर हॉस्पिटल्स में एमएस साहब का अपने स्पेशलिस्ट डॉक्टर्स के साथ जो रिलेशन होता है, वो आप उस्ताद शागिर्द वाला ज़्यादा समझें, ऑफिसर और सबॉर्डिनेट वाला कम समझें. तो इस वजह से भी एक ही मसला आ जाता है. दूसरा ये है कि प्रोक्योरमेंट्स के हवाले से अगेन मैंने कहा 10-20 साल से गवर्नमेंट के अंदर एक मोटिवेशन या एक इनिशिएटिव लेने का जो एक ख्वाहिश होती है, एक तरीका होता है, वो बहुत कम हो चुका है. तो ईच एंड एवरीथिंग के लिए उनको गवर्नमेंट के पास आना होता है. सो मच सो कि उनको लोकल परचेज की मेडिसिन की अप्रूवल के लिए भी सेक्रेटरी हेल्थ के पास आना पड़ता है, जबकि विच इज़ एक्चुअली 180 डिग्रीज ऑपोजिट ऑफ व्हाट वी वांटेड टू डू इन दिस प्रोग्राम, दैट इज टू मेक एम्पावर द एमएसएस. तो एक तरफ हम उनको एम्पावर कर रहे हैं इकोनॉमिकली और ऑपरेशनली हम अपने तौर पे, बट उस स्टार्ट तक पहुंचने के लिए दोबारा एक रेक्टिफिज्म का बहुत बड़ा प्रोसेस है. जैसे मैंने मिसाल दी कि लोकल परचेज के अप्रूवल के लिए भी यही सेक्रेटरी साहब बैठे हुए, इनको पता है. अब सेक्रेटरी साहब जो है वो तो सेक्रेटरी जॉब के नहीं है कि सारा दिन डेस्क पे होते हैं, उनके 70 और काम होते हैं. और मेरे लिए बलूचिस्तान का सबसे बड़ा मसला हेल्थ कार्ड है, बट सेक्रेटरी साहब के लिए 70 मसलों में एक मसला सेहत के अंदर हेल्थ कार्ड है. तो दिस इज वन प्राइमरी रीजन. दूसरी बात, मैं अपने साथ साथ थोड़ा स्टेट लाइफ को भी इसका मोरल इल्ज़ाम ठहराऊंगा. वो इस तरह के 4 वो हॉस्पिटल्स DHQ जिनकी अप्रूवल भी आ चुकी है, उन पर अभी तक स्टेट लाइफ की तरफ से भी डेस्क नहीं लगे हुए. तो अगेन मैं आपका वकील बनते हुए कहूँगा कि आप भी इसी माशरे के रहने वाले और गवर्नमेंट साइड भी उसी तरह है. तो हमने इसके साथ साथ एक थोड़ा स्लो गो पॉलिसी भी इख्तियार की. जब आप एक साथ 12-15 काम करते हैं, एक्सपेंशन बहुत ज़्यादा करते हैं, तो ऑब्वियसली क्वालिटी कंप्रोमाइज़ होना शुरू होती है. तो एक नोवे से एक नया प्रोग्राम है, हमने साथ में हमने इस तरह थोड़ा स्लो इसलिए कर दी कि हम कोयटा से यहाँ पे एक दफ़ा अपने जितने भी हॉस्पिटल्स हैं उनको एक पूरा सिस्टम समझा दें. और वही कोयटा का हॉस्पिटल का एमएस जितनी अच्छी ज़बान में किला सैफुल्लाह को एमएस को समझा सकता है, उतना मैं और आप शायद उतना अच्छा समझा नहीं सकते. ये नेचुरल तरीका है. तो हम इस पॉलिसी के तहत भी जा रहे हैं. और जैसे मैंने कहा कि अनफॉर्चुनेटली गवर्नमेंट के अंदर जो है द रिजॉल्व टू डू समथिंग एक्स्ट्रा ऑर्डिनरी और इनिशिएट समथिंग की ओवरऑल कम हो चुका है. और अनफॉर्चुनेटली it will also be part of the nation building under which we are going now.
कोई दूसरा
I just would like to add to what Mr. Jalal said. I think the problem lies, and CEOs have also referred to, with the institutional framework currently we have. Things are very much centralized. Powers are very much centralized at the secretary level, or it is almost at the secretary level. We initiated certain reforms. One of the key reforms was to give semi-autonomy to the tertiary level facilities here in Quetta, and then at the later stage, seeing the success, we wanted to go to the divisional level hospitals as well to provide them, to make them semi-autonomous, so that they have their own mechanism, and secretary at the provincial level has very less say into how it should be lying there. I think the Chief Minister has, in principle, approved the summary which was moved that time, and I believe, I'm not sure, Mr. Shaku may be aware, or people sitting here from Health Department, I believe it is supposed to be now placed before the Provincial Cabinet. Once it is done, it is going to help out these hospitals. Second is the delegation of power, a very comprehensive proposal we submitted. And we also presented it to the Chief Minister, then we presented, first of all, we presented it to the Chief Secretary of the province. He agreed, along with Finance, SNGAD, Law Department, the key departments, they were sitting over there. And then we presented it before the Chief Minister as well. So the policy makers, they have agreed upon. I'm not sure today, I was asking the PS to Secretary Health if that summary has returned. That will delegate powers like what Asad Saab was saying, that will delegate powers to DG Health, the divisional directors of health, and the MSs at the district and divisional and district level, and as well as the district health officers. I believe that is going to bring some change, and then it can also be a very positive catalyst for the implementation of the health card, I believe.
Thank you, sir. Wali Saab, Dr. Farooq Azam.
I am Dr. Farooq Azam, member Healthcare Commission. As far as the impact of the health card is concerned, I think it's too early. It's too early to assess or to give some opinion about the impact which has been created or assessed through this Balochistan Health Card at the moment. It will take time. It will take time, and then we can say that there is some impact or not. Because the Healthcare Commission is in the process of developing the standards, protocols, and the minimum service delivery standards, and as well as empanelment and etc. These will be catered later on. And when the total Healthcare Commission will be in its true form, it is implemented. So I think with the passage of time, when we will be able to implement the standards in the hospitals, and through the health card we can link these things, then we can get the results or impact. It is at the moment, I think it's too early to give an opinion about that. I think so.
Thank you. जी?
Answer to नहीं करनी पड़ेगी।
नहीं
Yeah, the comment.
Yeah, there's no comment. Thank you so much, Dr. Shako, and I think the panelists have already touched so many areas, but I would say that impact, we still need time, but your policies and the measures that you take, that also sets a stage for the direction. It also gives the direction where we are moving. And I think health financing is an area which is being, we are giving it, we are considering it as a savior right now. While it cannot act in isolation, it's the overall government policies, and I need, this is my question also, that how this program is cognizant of the other measures that not only the government, but particularly health department is taking. And I see that there are examples of going on PPP mode, and 10 of the hospitals and so many other examples are there. what is put in that initiative that would support our inclination towards improvement of public facilities, or quality of care in public health facilities? Second thing is this, that I also see that, first of all, its cognizance with the other measures that the government is taking. This is my question. That what regulatory features are being put into PPP mode, which is being undertaken. Because I see that there are certain examples where the budget of those hospitals has increased many folds compared to the time when it was run purely by the government. And I see that, some small hospital in some periphery is becoming at par with a major tertiary hospital in terms of monetary incentives that will be given to the private partner. So that's the big question. We are actually by policy obliterating that difference of public-private facilities. It's not only the HR that they sit in the morning here and they are only the people. And with minor changes within card program, we can tackle that issue. I mean, with a small measure, why don't we start OPD services in the public facilities also on payment, as they are done? We need to bring it at par first. And that is a small measure. And then I also see that there is a disconnect of card with the issues that we face. For example, our ratio of doctor to nurses is inverse. And same is seen in the incentives paid to the nurses. There is a drastic, there is a radical, difference between the incentive paid to the doctor. At least it should be narrowed down. Because our problem is paramedics and lack of nurses. And through incentives, we are paying to those who are already getting double. They sit in the morning, they go in the private sector, and they are getting 30%. And then for the nurses, it's 50% with the least chances of them going into private sector and practicing there. So see, these are small things that are promoting private sector. They are not promoting quality of care improvement in public. Then strategic purchasing, as one of the colleagues mentioned. We are so much tight, or we have put thresholds on funding expenditure criteria. 20%. The public facility may need money in medicine, may not need in HR. So we need to be flexible in that what we are buying, and it should be cognizant of what is the need and what is being provided. That strategic purchasing is one of the areas. So my question is, like we are dealing with the health financing in isolation. We need. This is my question, that what these new initiatives that the government is taking, which are encouraging, but how the card is cognizant of that. Healthcare Commission is another thing that is coming around, and then the divide of this, divide of functions is also important. Now the health department is sort of becoming only purchaser, which we need a clear-cut demarcation, not between public and private, but also among the purchaser, regulator, and the services provider. So these are two questions. I think I may be jumbling them up, but you people can take it one by one and answer by your choice.
Sir.
I can only answer.
Actually, you have answered to your question.
Like
Your questions as well.
Since my focus will only remain within the context of health card, therefore I can only answer that part of it. We are actually doing the opposite of what you want us to do. We want to break the difference between public and private hospitals in health card, and this is actually what happens. Now in Quetta we have 24 private hospitals. A government hospital is a place where you are not charged for your services, and in a private hospital you are actually charged. All of those 24 hospitals are places now where you can go like you go to any government facility. Similarly, the reverse comes in the government hospitals. Any doctor who will attend to a patient under the health card will be getting fringe benefit, economic incentive. And if he does not attend to that patient, he will not be getting that money. This is what exactly is like the government private sector practice. Now, your question is in a broader context where the government has to look into the things of properly differentiating between that. And for that, I think the Secretary Saab will be in a better position to answer it. Sir, over to you.
Yeah, of course. Thank you. One of your questions, then I will also highlight upon what Asadullah asked me. One of your questions is that through health card we are actually promoting private sector. I tell you one thing, we should promote private sector because it is already the mandate of the health department. Health department has legislation It was done long ago. And health foundation was established long ago, I think 2 decades back, maybe in 70s or 80s, I'm not sure, or maybe in the early 80s, yeah, in the late 80s. The mandate of the health foundation is actually to promote private sector in the areas where it is non-existent. Whenever we refer to the private sector, we talk about Quetta city, or Khuzdar, or Lorwai, or Hub district. In Washuk, we don't have private sector, do we?
No.
In majority of the districts in Balochistan, majority, 80 to 90% of the districts, we don't have private sector. And the government of Balochistan Health Department has always wanted the promotion of private sector in the areas where government cannot provide services. Now through health card, if I've seen there are case studies in some of the districts, people have started building hospitals, private hospitals, due to the reason, since financially the hospitals there in those districts are not viable, but due to the advent of the health card, private hospitals are becoming financially viable. I'm talking about financial viability, which is a very key area in the public-private partnership domain. Unless any of the projects are financially viable, they cannot be implemented. Then the government is to incentivize, the government is to provide subsidies, etc., etc. So I believe positively if we start thinking that we require private sector, and if, according to you, the health card is promoting private sector, I think it is a success story.
No, it is, but that's why we are looking so much or focusing on improving public sector. When we are already, inclined towards improving private.
No, we are not inclined.
Then that
it is the
question
policy, the health policy actually covers the development of private sector because government lacks resources. Now, in China, just tell you one example of Chinese model. These small and medium-sized entrepreneurship in China, they have created a kind of competition among the public sector entities and public and private sector entities, due to which it is said, according to some studies, China has had this rapid growth. So if there is competition among the public sector hospitals and between private and public, I think we can have it positive, but we have to have what the other aspects of your question are. Initially in my talk I referred to, we have to have a regulatory framework for which Healthcare Commission is a ray of hope, I believe. That is going to be an institution to regulate, because regulatory framework in the capitalist society is very much essential.
Thank you, sir. I think Dr. Franz wanted to say something. Dr. Asadullah, sir?
मेरे सवाल
1 minute.
Thank you. I have one statement or the answer to one question, my answer, which is the base for 3 questions that I have, if I may. I will be very short. I think this discussion here, there are questions concerning this game, and so for me, the impact is already there. That's why I have 3 questions. I think there are many more, but based on the discussions. The first one is, I won't ask you for the definition of public and private. I will rather ask you, why do you want public and private? And why do you want public and private? Why do you want this distinction of the two? And of course, with the why comes what is your definition of that? And I would think, in order to use this game changer, this should be a fresh question. Look at the past, but also look at the future. Number 2, you have talked about the competition of the public and the private. Think about it when you think about stewardship. Can you actually have a health ministry, a health department that is the steward of the health system, which at the same time is the boss of all public doctors, and hospitals, and it's an entrepreneur? So is that possible? My answer is no, but I think it's more important to ask yourself the question than to have an answer right now. And the third one is, as a standalone instrument, this health card is good until this very point. But if you leave this alone for longer, my hypothesis would be example, we talked about it cannot take over financing functions. Yeah, it's purchasing and not financing, and the two already get mixed here. So my question to you is, what is the absolutely necessary next step to make sure that this health card program can further thrive and is not endangered as soon as it has already existed?
The first question is the dichotomy of public sector and private sector. I don't believe in this dichotomy. If I wear the head of a government, then I have to provide access, no matter from where I provide the access. So that is my first statement. The second statement is, if you are analyzing a policy, then the question is from whose perspective? From the government perspective, from the provider perspective, or from the public perspective? Now, if you look at it from the government or the provider perspective, this dichotomy matters. But if you look at it from the public perspective, which matters to me, it does not matter. Because the sector which is more responsive to the needs of the public, which is more innovative and can adapt technology rapidly than the other sector, will provide better services to the patient and to the public. So therefore, in my view, this dichotomy essentially is not necessary. The second question was, what essentially needs to be done? I would say, we are discussing the carrot element. We are not discussing the stick element. You have the Healthcare Commission, which is the stick, and they do not have a place to keep the stick. They do not have an office. You know? Now, how can a regulator regulate when they do not, which they do not at least have the basic necessities? So I think as a necessary first step, friends, if we want to see this program a success, we will have to improve the regulatory function. And the last point is a standalone financing the answer. So if the objective is to improve access, financing can improve only the financial access. It cannot improve the geographical access. If you have an undersupply of providers in an area, no matter how much money I have in my pocket, it will not improve it. Can I improve the acceptability of people of a sector or a hospital which does not enjoy the reputation by empaneling it? No, I cannot do that. So it is a partial solution. It essentially is not the silver bullet to all the underlying problems.
With the aim,
Sorry, I just wanted to add, because one of our colleagues just talked about, number one, we have to agree what is a partnership in this. Are they going to put the same amount of money as the government to ensure that facility works? No. It's simply contracting out. Management contracting is that take government's money and improve the facility.
That's why the cost is increasing.
So we have to really...
Because it is not financially viable.
So we have to really rethink. I can answer, but I think we will increase the discussion. I think he wants to have some other questions.
with the aim of...
One thing I just would like to add, with regard to the regulatory framework which we require to help strengthen, Healthcare Commission, there's the monitoring and evaluation system existing at the health department. This is another area. And the health card, they have got their own monitoring framework which is supposed to be improved. Also with the state life of Pakistan, they also have their own monitoring and evaluation framework. So all these frameworks, all these tools, instruments and institutions we require to focus upon them to have a kind of integration among them. This is also one of the areas I just wanted to highlight.
Sir.
I'll answer the sustainability part of it, your third question, which as you all know, in the case of Balochistan, the total budget that is required for the entire province is 2.3 million. And one very salient feature of this program in Balochistan is that from the very first day it has been announced as a universal program, meaning thereby that each and every person who holds a CNIC from Balochistan is eligible, be it the Prime Minister or a non-governmental card guy. Secondly, it does not carry anybody's name, party, flag or picture. This is also one salient feature of it which the other programs do not hold. And probably this is the main reason that successive governments, the incumbent chief minister is the fourth ever since the program was launched, and he is the fourth CM, but then we have not got a single call any day from the chief minister office or the chief minister telling us to stop or to change even a single dot in the program. Rather, each and every coming CM has helped us more than the previous ones. It is because it has remained apolitical and it will remain apolitical. Even if it is at its maximum utilization, the amount that is required will be 6 billion, as I told you. Now, in the morning, you were all told that government servants that are 400,000 in the province had around 2 billion was spent on their reimbursements. Now, 400,000 people, 2 billion, and the whole province, 6 billion at its maximum. So this is for starters. Secondly, we also know that inflation and utilization will go on and on to a point where probably the government will not have the money to fund it. For that, we are working on 2 to 3 short-term and medium-term plans. From next year on, we will exclude all the government officers and all those corporate work people who are from Balochistan but who are being double-dipped. We will exclude them. And then probably from the third year, we are also looking into ways of taking some co-payments from people who under the excise department have a registered car or who under the FBR have a certain level of economic stability. So these are different ways, but as I said, I mean, Alhamdulillah, in the case of Balochistan, population being less is one good achievement or salient feature for us. Thank you.
With the aim of wrapping up the first thematic area, because we have another one, we'll just take the last question because she's been waiting for a while. Dr. Safia, please.
Dr. Safia Mengal, Director, Institute of Public Health. My question is regarding the feedback. For example, I will elaborate कि हम जैसे आवाहन विजिट करते हैं शिफा इंटरनेशनल, तो 24 आवर्स तक हम अपने जैसे ही घर पहुंचते हैं तो हमें हॉस्पिटल की तरफ से एक मैसेज आता है कि आपने जो यहाँ पे विजिट किया था तो उसके बारे में आपके फीडबैक्स क्या थे. तो उसमें ये होता है कि उसमें हमें जो कंसल्टेंट थे उनका, स्टाफ का, सबके ये फीडबैक उनको इसलिए ज़रूरी लगता है कि इससे वो फर्दर अपने स्टेप्स जो है ना लेने के लिए उनको ईजी लगता है. तो हमारे पास हेल्थ कार्ड में मैं कहती हूँ फीडबैक का क्या मैकेनिज्म है? क्या उस डेस्क पे आप लोगों ने कोई फीडबैक फॉर्म रखा है या जो पेशेंट जिसको यूज़ कर रहा है उसके मोबाइल नंबर पे मैसेज चला जाता है? मतलब मुझे इस फीडबैक के बारे में
असद साहब सर. अच्छा, आई डोंट नो, सुबह से इतने सेशंस में ये बात वैसे किसी ने नहीं की इसलिए इस प्रोग्राम में जैसे आपने बताया था कि 2 से 3 साल तक बाकी सूबों में प्रोग्राम चलता रहा, तो वी केम इनटू द प्रोग्राम एट अ लेटर स्टेज, बट इससे हमें फ़ायदा हुआ, कोर्स करेक्शन हो गई और जो इम्पेडिमेंट, जो मसले मसाइल दूसरे प्रोग्राम्स को हुए थे वो हमने पहले दिन से ही प्रोग्राम में इनकॉर्पोरेट करके कोशिश की कि वो मसले होना. दूसरा इसमें बड़ा अच्छा है डाइकोटमी ऑफ पब्लिक एंड प्राइवेट में तो हम बात नहीं करेंगे, बट डाइकोटमी ऑफ ड्यूटीज़ एंड पावर्स हमारे इसमें बड़े अच्छे एक्सप्लेन हो चुके हैं. हम मॉनिटरिंग करते हैं, ओवरसाइट करते हैं एज ए डिपार्टमेंट और एज ए प्रोग्राम मैनेजमेंट साइड. सर्विस प्रोवाइडर के साथ जो है वो स्टेट लाइफ डायरेक्ट कॉन्टैक्ट करता है, डायरेक्ट रब्ता रखता है, डायरेक्ट कोऑर्डिनेट करता है. और क्वालिटी एश्योरेंस के लिए जो है और फीडबैक कॉल्स के लिए हमने तीसरे डिपार्टमेंट को साथ इंगेज किया, दैट इज़ नादरा. तो हम मॉनिटरिंग करते हैं क्वालिटी की. सर्विस के लिए स्टेट लाइफ बैठा हुआ है और सर्विस भी इंश्योरिटी के लिए और क्वालिटी के लिए थर्ड टियर पे नादरा बैठा हुआ है. जितने भी हॉस्पिटल्स के क्लेम है दे आर सब्जेक्ट टू अ फीडबैक कॉल फ्रॉम नादरा. नाउ नादरा इन अदर प्रोविंसेस as per their practice has to I think call 70% of the total patients. लेकिन बलूचिस्तान के केस में हमने कहा है कि 100%. तो 100% में होता क्या है कि 10 से 15% लोग जो है अपना कोई किसी और का नंबर दे देते हैं. दूसरा वो हमारा अनफॉर्चुनेट साइकी है, जब काम होता है तो सब कुछ देते हैं, काम होने के बाद फ़ोन भी अटेंड नहीं करते हैं. बट एट द मोमेंट लाइक 87% of the people that have gone through this treatment process have all been called, not only called but verified कि उनका इलाज हुआ है, पैसे नहीं लिए. उसके बाद जो है फिर स्टेट लाइफ को ये मैसेज कन्वे होता है थ्रू द डिजिटल सिस्टम एंड CMIS एंड ऑनलाइन कॉल सेंटर. उसके बाद फिर हॉस्पिटल को पेमेंट होती है. और अगेन पेमेंट का जो टाइम है, हॉस्पिटल जब अपनी बिलिंग कर लेता है तो उससे 15 से 30 दिन के अंदर स्टेट लाइफ को पेमेंट करनी होती है. और एक और चीज़ जो यहाँ पे प्राइवेट सेक्टर में खास कर आ गई, हम बाजार से फिर टमाटर भी लेते हैं तो उसमें से ख़राब टमाटर निकाल के रेडी वाले को डांटते भी हैं. डॉक्टर के पास जाते हैं, मरीज की लाश भी देता है, तब भी हम डॉक्टर साहब का शुक्रिया अदा करते हैं और 6 लाख रुपए भी दे देते हैं। हम ये भी नहीं पूछ सकते कि यार आपने खुदा न खास्ता इस मरूम को क्या लगाया क्या नहीं। हेल्थ कार्ड में प्राइवेट सेक्टर के जितने भी डॉक्टर्स हैं, फ्रॉम अ सिंगल पेनी टू 1 मिलियन, जितने भी पैसे इसमें इनकर होते हैं, उस तमाम के तमाम का जो एक डिजिटल रिकॉर्ड भी बनता है। न सिर्फ ये है कि हार्ट पेशेंट्स का आपके पास सीडी मौजूद होती है, इससे एक गेम चेंजर के तौर पे हेल्थ डिपार्टमेंट में ये गेम चेंजर भी आ रहा है और इंशाल्लाह वो जो पैसे कर्टेल करने का या सिनर्जाइजेशन ऑफ रिसोर्सेज की जो बात की जाती है और जिसके लिए डॉक्टर फारूक साहब ने भी कहा और मैं भी कहता हूँ इसके लिए थोड़ा टाइम लगता है गवर्नमेंट में खासकर। Probably by the end of the 3rd year जो है आपको नजर आएगा कि ये 6 बिलियन एग्जिस्टिंग 60 बिलियन में से निकालना या साइडलाइन करना इज वेरी इजी, क्योंकि डुप्लीकेशन भी बहुत जगह पे हो रही है। तो आपके क्वेश्चन पे जैसे मैंने कहा कि फीडबैक कॉल होती थी, बट इट इज अ कंडीशन टू पेमेंट टू द हॉस्पिटल्स।
थैंक यू सर। वैसे तो सवालात से सवाल जन्म लेते रहेंगे और वी वुड लाइक टू raise many questions, but we can't answer all of them. We'll let them simmer. Maybe someone will have a eureka moment at home. So, sir, I'll put the second thematic area and core question before the panelists. Given the existence of various fragmented pools, like we discussed, we have RMC, we have Awami Endowment Fund, we have Health Card, there are several others, such as the reimbursement of RMC, Balochistan Awami Endowment Fund and Health Card, and private insurance schemes. Do you believe we are creating unnecessary duplications? If so, can we consider excluding members of these pools from the Health Card Program? Masood Saab touched on some things. Or should we explore unifying these pools into a single larger one, which Nurulak Saab had suggested in the morning? We will start with, I think, Dr. Imran.
Unified pool. Let's start from a unified pool. Before you define a unified pool, the benefit package has to be defined very carefully. Because if you are in a zakat, everything is covered in zakat. Maybe, but in insurance, everything is not covered. In the governmental pool, a civil servant can reimburse up to crores of rupees from the public reimbursement, but the insurance will not do that. So first you have to define the structure, how these things have to act together. And I will give you an example, and I think there's a German example sitting in front of us also, that in Thailand there is the NHSO, the National Health Security Organization, I think. Every organization which is part of that pool has a different premium and has a different benefit package. There is a civil servants there, there are farmers there are 30 baht schemes there which are now known as something else, but when I visited there it was known as the 30 baht scheme. The governmental servants are there, the blue collar workers are there. So all these are there, but everybody is providing a different premium and a different benefit package. So before we start thinking of a unified pool, we really need to see how these pools can be unified. That is very important for us to think about. And with this additional one thing which I just want to say is that kabhi aap zakat, I'm talking to, maybe I'm not talking in English because I think I will better explain that to you. जब आपको अस्पताल जाते हैं और आप अपना इलाज कराने जाते हैं और वहाँ जाके आप डॉक्टर को कहते हैं कि मैं गरीब आदमी हूँ, ना मैं डायग्नोसिस के पैसे दे सकता हूँ, दवाई के पैसे दे सकता हूँ, तो पहली बात कहता है अपनी यूनियन काउंसिल में से जाके लिखवा लाएं कि आप गरीब हैं और आप ज़कात लेने के काबिल हैं। जब आप वो ज़कात लिखवा के ले आते हैं वापस, तो प्रोवाइडर पर्सपेक्टिव भी चेंज हो जाता है, कहता है आप जो कुछ करवाना है करवाओ, ज़कात में पैसे देंगे। So with unified pool, I mean we really definitely need a unified pool, not because of the premium, but for providing a complete social protection picture. we have to think about it. But ensuring that every pool is different from the next pool.
Sheraz, sir.
Yeah, thank you very much, Dr. Imran. And I'll further build on that. So when we ask merging the pools, which pool are we talking about? Is this the risk pool, that is the disease pool, or is it the financial pooling or the resource pool? Now, if we look at it, the financial pool is already one. When the entire money for all the programs is coming from the finance department, then you have a single pool. Why do we even discuss pooling of resources if we are not raising any extra money within the programs? This is number one. Now comes the next question. In the intermediate term, I think if those smaller subsections of the risk pool are getting comprehensive coverage, then let's leave them alone. If their coverage is not comprehensive, then let's have a coordination of benefit package with them. That what is not covered there is covered over here, and what is covered over there should be excluded from the benefit package over here. And number third, I will not recommend merging the pools in a way that it brings in the territorial disputes. Because if a pool means sending some people home, they will be in the court the next morning, and the existing mechanism that you are having will be a failure. So I would say we need to be very clear which pool we are talking about, number one, and I think it is better to have a coordination of benefit package rather than merging everything together. The last thing, Abdullah Saab gave me an opportunity, and I unfortunately couldn't avoid it properly. What is the experience from KP and what is pooling? Now, there is a notorious smuggler, a cartel ringleader in KP. He built a ₹1 billion hospital and empaneled it at Health Card. And someone said, it's smuggling money and now he's making money on that. And I was like, look, he spent ₹1 billion over here. Now think of it this way, that this billion is not circulating in that business now. Think of it this way. So if you are bringing in additional money to any pool, then that is an important thing to do. But if we are not bringing in any additional money, then there is no point in pooling the pools which are already coming from a single pool. Thank you.
Abdullah sir.
Okay, this question of merging all the programs, for example, the Zakat program, Balochistan Awami Endowment Fund program, health card, and what the government, the health department is offering, that we have the regular protection for the employees. These all to be merged, this is a big question, a big challenge. Now we have two main departments. One is health department and one is finance department. If I'm posted in health department, my thinking is and will be to save lives. I don't care about money. I say I have to protect mothers, I have to protect children, I have to ensure health and well-being, right? The next day I'm posted in finance department. I'm worried about protecting money and resources. I'm not worried about, okay, what happens in health, what happens in education, what is the literacy rate, what is the maternal mortality rate, the infant mortality rate, etc. and etc. So for that I believe, because when you are sitting in finance department, if Dr. Sheraz is now today posted in finance department, he will start thinking otherwise with certain period of time after spending some time in finance department. We have to have merger. How is the question? Why? Because finance department always asks, whenever Asadullah goes there, approaches finance department for financial enhancement, the allocation enhancement, they say, no, we are giving to endowment fund, we are giving to Zakah, we are giving to the other program, so why should we increase for you? Come up with your impact. They ask for impact. Impact, we have to have time for that. They always ask, this question is always asked. And then the politicians look at us, the cabinet members. Okay, what is the impact? We are then answerless. So for that, I think we have to agree that merger is essential, but I agree to the extent that how we are going to have it, because the Balochistan Awami Endowment Fund, they cover certain diseases, tertiary level diseases, and they pay for the complete entire treatment of the disease, plus the best hospitals in Pakistan, like Khan Hospital, PIMS, and etc., they are embedded there because they can afford them. While under the health card, we cannot afford those hospitals. Right? This is another challenge. So if you're going to merge, the how part becomes difficult, because then we have to change the entire framework under this program, and then we have to go for the framework for the system, which should also cover Aga Khan and the other high-class hospitals in Pakistan. So this how part is very much difficult part of it.
थैंक यू. अच्छा, आप उर्दू में बात कर लेता हूँ. मर्जर के हवाले से देयर आर two different scenarios on it. First of all, let me just give you a small brief on the comparative side of it. Awami Endowment Fund 8 अरब रुपए इसके seed money है, और it is almost into its 7th year. Health card started 10 months back. Health card में we have treated around 89,000 people. Awami Endowment Fund में we have treated 4,000. This is just a comparison. It's not like for Awamis. Or now the second thing is, and this is what I tell each and everybody as a success story of health card. Out of the 89,000 people that have been treated in different parts of Pakistan, उनमें से मैं कसम खा के कह सकता हूँ कि मेरे स्टाफ और मौजूद में से 8 लोगों का भी नहीं पता है. So in the government sector, that is a revolution. कि अगर आपके 89,000 लोग जिस पे 2 अरब से ज़्यादा खर्च हुए हैं, जो कि थर किया है, मीरपुर आज़ाद कश्मीर किया है, बाग किया है, हर कहीं गए बलूचिस्तान के लोग, पैसे उन पे खर्च हुए हैं, फीडबैक कॉल के तहत वेरीफाई हुआ है, डिजिटल डाटा मौजूद है, बट एज ए सीईओ मुझे पता भी नहीं वो कौन था कहाँ था, जबकि नौकरी के लिए मुझे अपनी डिग्री को भी सर्टिफाई किसी से करवाना पड़ा. तो एक तरफ आपका गवर्नमेंट इस तरह चलता है कि आपको अपनी डिग्री भी दोबारा किसी से सर्टिफाई करवा के टेस्ट करवा के लानी पड़ती है, और एक तरफ एक आदमी जिसने सिर्फ और सिर्फ कौमी शनाख्ती कार्ड दिखा के किया. तो अवामी एंडाउमेंट फंड में भी इस तरह मसले आ रहे हैं कि मेजर बीमारियां तो ट्रीट हो रही है, बट एक आदमी के घर में जब कैंसर का पेशेंट होता है तो उसको आप सरकारी दफ्तरों के चक्करों में नहीं रुला सकते, न एक महीना बोर्ड मीटिंग्स के लिए इंतजार करवा सकते हैं. एक तो अब दूसरी तरफ लकीली द पीपल दैट आर रनिंग द हेल्थ डिपार्टमेंट आर ऑल गुड मेजर रिस्पेक्टेबल, और उन्होंने ये किया, खासकर मुल्क साहब ने इन चीज़ों को सबको फोकस में लेते हुए कोर्स करेक्शन या वे आउट क्या है, वे फॉरवर्ड क्या है, वो ये है कि हम 2 एवेन्यूज पे काम कर रहे हैं. एक तो ये जैसे मैंने कहा, हम सरकारी लोगों को और कॉर्पोरेट सेक्टर के लोगों को कोशिश कर रहे हैं कि हेल्थ कार्ड से हम निकाल दें, बट अब मैं बिजनेस साइड में भी बता देता हूँ कि क्या इम्पैक्ट आएगा. इम्पैक्ट विल बी लेस देन 1%, क्योंकि अगर आप एक खास चंक ऑफ पॉपुलेशन को हेल्थ कार्ड से निकाल देते हैं तो जिस टाइम आप हेल्थ कार्ड के काउंटर पे जाएंगे आप दोबारा वेरीफाई होंगे, वो पहले चेक करेगा कि ये सरकारी तो नहीं है, टाइम डिले आ गया, वेरिफिकेशन का टाइम ज़ाया होगा. दूसरा, 4 लाख से 6 लाख लोगों को अगर आप 1.5 करोड़ की आबादी से निकाल भी देते हैं तो स्टेट लाइफ के जितने भी बेनिफिशियरीज कम होते जाएंगे, इतना प्रीमियम का रेट बढ़ेगा. इट इज़ ऑल फॉर बिजनेस. बड़ी कॉमन बात है, आप 2 चीज़ें खरीदेंगे, एक रेट पे मिलेगा, 200 लेंगे कम रेट पे मिलेगा. तो इस हवाले से हम इस पे, बट ये जो सर की बात है कि हम दूसरे प्रोग्राम्स, हर प्रोग्राम के कुछ ना कुछ खूबियाँ हैं. हमारा प्रोग्राम बहुत अच्छा है, बट हेल्थ अवामी एंडाउमेंट फंड में कुछ ऐसी खूबियाँ हैं कि मैं 100 दफ़ा भी कहूँ वो हमारे प्रोग्राम से अच्छा है. आगा खान में आप इलाज कर सकते हैं, नो लिमिट पे आप इलाज कर सकते हैं. तो ये मुख्तलिफ हमने क्या किया है कि हम कोशिश कर रहे हैं कि जो थ्रेश होल्ड होगा, वो बेस होगा, दैट विल बी हेल्थ कार्ड. हम कोशिश करें, वी आर वर्किंग ऑन 2 डिफरेंट मॉडल्स. एक तो ये कि गवर्नमेंट का ऑफिसर पहले अवेल करे हेल्थ कार्ड को, हम इस पर भी काम कर रहे हैं. हेल्थ कार्ड पे अवेल करे, और जो सेक्टर्स हेल्थ कार्ड से के अंदर कवर नहीं हो रहे, RMC से उसके ले रहे. इसी तरह हम इन्हें इस पे भी काम कर रहे थे कि सोशल एंडाउमेंट फंड में भी जो है, जो बीमारियां 10 लाख से एक्सीड कर रही है, वहाँ जाके फिर वो दूसरे एवेन्यूज को अडॉप्ट करें. बट इस पे हम काम नहीं कर सकते थे, तो हम गवर्नमेंट ने इस बात पे इन प्रिंसिपल एग्री किया है कि सोशल एंडाउमेंट फंड विल बी मर्ज्ड इनटू हेल्थ कार्ड. इट विल हेल्प अस इन 2 वेज. एक तो उसका जो सीड मनी आएगा, उससे हमारे पास जो है एक सस्टेनेबल परमानेंट पोल मिल जाएगा. दूसरा, जो लोग वहाँ पे इलाज कर रहे थे उनके ऑलरेडी यहाँ पे पैसे हम स्टेट लाइफ को दे रहे हैं, तो ये भी बच जाएंगे. साथ में हम गवर्नमेंट सेक्टर में हमने नोट किया है कि, और इट्स बीन ऑलमोस्ट 10 months, और 1 साल के बाद वी विल पब्लिक आवर स्टेटिस्टिक्स. गवर्नमेंट सेक्टर के लोगों ने सबसे कम इसको अवेल किया है, और वो नेचुरली जाहिर बात है उनको दूसरे ऑप्शन ज़्यादा फिजिबल लगते हैं, ज़्यादा बेहतर लगते हैं कि एक अटेंडेंट के पैसे भी मिल जाते हैं, कराची का चक्कर भी लग जाता है, आगा खान से भी इलाज हो जाता है, तो वो उस पर ज़्यादा खुश हैं। तो बाय द एंड तो हम कोशिश ये कर रहे हैं कि गवर्नमेंट के लिए हम एक टॉप अप कैटेगरी इंट्रोड्यूस करवा दें, उनको हम सिल्वर कार्ड या गोल्ड कार्ड के नाम से होगा। तो ये जो बेस लाइन पे हमारे रिसोर्सेज होंगे वो तमाम बलूचिस्तान के लिए इक्वल होंगे, बट गवर्नमेंट के जो लोग होंगे लिए हम एक एडेड फीचर उसमें होगा कि ओपीडीज भी होंगे, और ये जो ब्रांड हॉस्पिटल जिनको मैं कहता हूँ पाकिस्तान में जिसमें हर एक जाना चाहते हैं वो भी इनके लिए एक्सेसिबल हो जाएंगे। तो ये हमारे फ्यूचर उसमें भी शामिल है। थैंक यू।
Would any of the panelists like a rebuttal?
वो तो चलता रहेगा मेरे ख्याल में। I think you should move ahead because what he thought something else.
इस क्वेश्चन के रिलेटेड जो मैंने प्रॉम्प्ट्स तैयार किए थे कि अगर कोई चीज़ मिस होती है तो हम प्रॉम्प्ट करके कोशिश करें कि इट इज़ ऑल्सो डिस्कस्ड. I don't know, luckily or unluckily, all the prompts have been discussed in this dialogue between the panelists. So if there is no rebuttal, we can move to 2 or 3 questions at most from the audience if they would like it.
Assalamu alaikum, I am Hussain, common citizen of Pakistan. So just a question, I see health as a public good, and in public good I see it as my right. What are we doing from a general public perspective to educate them, to hold people responsible if they are asking for a service and it is under the healthcare card or any insurance scheme that the government is offering? What are we doing to empower the actual patient if he has been mistreated? So one of the prime good example, one of the panelists said, like, patient mar bhi jata hai, 6 lakh rupees bhi dete hain, we can't even ask why. So what are we doing to educate people, to empower people, to explain them their rights? If I as a citizen would know this is what my right is, I can ask why the surgeon is not on time. What are we doing on that front?
So maybe we can also take the second question from Dr. Franz and then come back to the panel.
Well, that was already a very good question, so I don't want to compete with that one. Again, in the logic of this event here, policy workshop, my question is also policy related, and I just heard again you are discussing pools, and that's very important. These are important because there's a new pool on the block, so to speak, and now what to do with that in relation to the others. That is, in my understanding, again, one of those essential, decisive questions that need to be answered. But I did not hear, and that's why I'm going to ask a question, because I did not hear a very precise distinction between the risk pool and the finance pool, and that is, I think that's necessary before you can do anything with pools, because right now you have pools that somehow mix functions of the two without this being very clear. And so my question is, would it not be time to start something like a health policy unit that actually prepares the type of regulations and that enable the decision makers, the policy makers and the political decision makers to take decisive steps? Because paradise is nowhere in sight, so there are no ideal decisions in this. This is going to be a tailor-made program which has to advance as it goes along. Also some trial and error, but I think it is now, it's risky to not address this systematically and leave it to some public debate, and maybe that also goes for the relationship with the consumers, who are, after all, the gold measure of everything is the population, and that is also not clear. So my question is, wouldn't it be necessary right now to start thinking of some kind of an institution that actually works on the whole policy framework that is necessary to make use of those pools now.
Thank you. Sir Asad Saab, I think first the question regarding how health can be considered a public good, and if it is a public good, the consumer has a right to hold the provider accountable.
Let me focus on what we have done and not what we will do or what we are doing again. As I said, 89,000 people treated. Out of those 89,000, even 8 are not known to me. They went simply with their CNIC. They were at liberty to select any of the 1,200 hospitals across Pakistan. They were at liberty to take along anybody with whom they wanted. They were at liberty to select their own choice doctor. This is actually empowerment. You are empowered by the government with an amount of 1 million rupees to access any of the 1,200 hospitals at any given time of your own choice. So this is actually empowerment. Now, having said that, in addition to that, you said if there is a complaint somewhere. Now, whenever somebody puts in a general statement like that, my next question is always to identify a certain time where you or any relative or a friend of yours has gone to any hospital where he or she was not treated. If you do have a case, please highlight it so that I may work on it. If you know it, let us all know about it. Kaun sa case tha?
Just an example to quote, brain hemorrhage patient went to one of the hospital and was told,
one of the hospitals, or do you know the name?
I can ask for the name. I can ask for the name, but
do not know about the name or the name of the patient. I mean, I am not asking about your question or statement, but generally as a government servant, I am always more sort of liking to have questions where something is pointed out, so that I may resolve the issue. बाकी generalized statement में तो मैं भी कहता हूँ मुल्क अच्छा नहीं चल रहा है. तो as a government servant, I always request people हमारी बेहतरी इसी तरह होती है. The second thing is, yes, one of the reasons of putting in Nadra into this program, other than that CNIC part, both are feedback calls. Now, feedback call is a complaint generating process. Each and every hospital that is impaneled under the health card regime has a counter at the entrance of the hospital where you have a person called the HFO. And on that counter is pasted or posted a poster on which all the salient features of the health card as well as the complaint or feedback call number is noted down, which is in every counter that we have on those hospitals. So it is the job of the public to approach or to dial that number and sort of register and lodge their complaints. And this is also one thing that I will take benefit of your presence in this room. जब भी आपकी कोई complaint हो, मेरी humble request है कि आप टोल फ्री नंबर पे दें. इसका फायदा पता है क्या होगा? जब हम 2 साल बाद स्टेट लाइफ के साथ बैठेंगे तो स्टेट लाइफ कहेगा कि 89,000 पेशेंट्स की ट्रीटमेंट हुई है और सिर्फ 900 लोगों ने कंप्लेंट की है. तो 900 आउट ऑफ 89,000 इज समथिंग लाइक वेरी गुड, 1% से भी कम है. बट मुझे भी पता है कि मेरे पास शायद 1000-2000 लोगों ने SMS के थ्रू भी अप्रोच किया होगा. तो जो भी इस तरह सिस्टम के अंदर, यही वो टूल्स है जिससे सिस्टम भी अपग्रेड हो रहे हैं और आपको भी एम्पावर कर रहे हैं. क्योंकि एम्पावरमेंट तो यही मैंने कहा ना कि सेक्रेटरी साहब, विदाउट ड्यू रिस्पेक्ट, सर को पता है कि RMC का एक केस भी इनके दस्तखत के बगैर नहीं किया. ये तो अभी 3-4 साल से सेक्रेटरी से DG को भी पावर्स देती है, जबकि हमारे केस में 2.5 अरब रुपए में एक बंदे को भी या 2 को, शायद मैं खुद जानता हूँ, मैंने सजेस्ट किया होगा कि यार फला हेल्थ कार्ड के हॉस्पिटल तो एज अ फ्रेंड, अदरवाइज हम जानते भी नहीं. तो एम्पावरमेंट पे भी काम करे और इंस्टीट्यूशनल डेवलपमेंट पे भी काम करे. बट इट इज अ 2-वे प्रोसेस. सिर्फ गवर्नमेंट का आदमी या सिर्फ सर्विस प्रोवाइडर का काम नहीं है. बेनिफिशियरी भी जो है उसके, जो अगर आप समझते हैं हमारे प्रोग्राम में अच्छाई आ रहे हैं तो खुदा के लिए इसको 4 लोगों को बताएं. अगर आप समझते हैं हमारे प्रोग्राम में गलती आ रही है तो उसके लिए वो टूल्स हमने दिए हैं. वो टूल इज द कंप्लेंट नंबर. वो टूल ये कि हमारे पास एक्सेस करो. तीसरा, मैं बार बार रिक्वेस्ट करूंगा कि जो भी जिस भी फील्ड में आपकी शिकायत हो उसको पिन पॉइंट करें. आप अभी के अभी अगर मुझे हॉस्पिटल का नाम और बंदा बता देते तो मेरे साथ स्टेट लाइफ का रिप्रेजेंटेटिव बैठा, हम दोनों कोने में जाके उस मसले का आपको बता देंगे. बट आपने भी शिकायत की, मसला हल भी नहीं.
Dr. Imran,
one just question, respond to his question, Ejaz. Second part of his question is very much important, that people should be educated to know this is the toll number they can lodge their complaint. So I think health card is already, the program is already working on. They have to have more and more programs to educate people that they should know they can lodge complaints.
in the insurance mechanism, वहाँ पे स्लिक वाले बैठे हुए हैं. They have a health facilitation officer in every hospital. And as soon as a patient, आपने फरमाया कि वो brain hemorrhage था, so brain hemorrhage is definitely a fatal disease and catastrophic in itself. Would definitely having the national identity card will be approaching a hospital where a HFO would be sitting, health facilitation officer is sitting. So saying that person को किसी ने treat नहीं किया or there was not a surgeon available or whoever, whatever the issue was, would be a kind of not the complete picture. Would not be the complete picture. Because the insurance mechanism, because I have been part of this insurance mechanism for काफी सालों से, तो उसके अंदर ये हमने mechanism रखा हुआ है कि स्लिप का हर हॉस्पिटल में एक facilitation officer है. So if there is a problem, कंप्लेंट तो फोन करेगा, उठाएगा, कोई किसी को कॉल करेगा, वहाँ पे एक बंदा बैठा हुआ है जिसको वो उधर ही कह सकता है कि यार मेरा where is the surgeon, my patient is dying right now. ये और ये I think ये उस टाइम बहुत पहले ही हमने डिजाइन किया था ये काम, आज से कुछ साल पहले. So I'm not trying to justify this thing, but I'm just trying to answer your question in a way that yes. And one important question is that जब हम खैबर पख्तूनख्वा में इन लोगों ने एक पॉलिसी बोर्ड बनाया हुआ है, and my debate to them always is that उसमें बहुत से एक्स सेक्रेटरीज हैं, बहुत से बैंकर्स हैं, बहुत सी और चीज़ें हैं, but I think जिस तरह के आप हैं, you are a consumer person, you should be included in those boards. On those boards, because these are the questions which maybe we will not be able to think, because मैं तो डॉक्टर हूँ, मैं तो अस्पताल पहुँचने से पहले मेरे लिए बंदा वहाँ बाहर खड़ा हुआ होगा, maybe but एक आम कंज्यूमर को ये प्रॉब्लम्स हो सकती हैं. So I think whenever we have discussion at a larger debate, the consumer's voice should be at the most.
So, thank you sir. So coming back to Dr. Francis' question, sir वो आप उसका जवाब देना चाहेंगे? वो कह रहे थे कि कोई हेल्थ पॉलिसी यूनिट, कोई ऐसा इदारा, कोई ऐसा मैकेनिज्म जो गवर्नमेंट को इन्फॉर्म कर सके ऐसे फैसले लेने के लिए या ऐसे फैसले लेने से पहले, ताकि जो फैसले निकले वो साउंड डिसीजंस कैन बी मेड.
जी, एक्चुअली 21 years ago we started a health sector reform unit in Khyber Pakhtunkhwa, which was developed to develop evidence on health, look back and see what are right mechanisms to, and I think मेरे ख्याल से आप लोगों के लिए. But the problem with that health sector reform unit is not that it doesn't do research, it becomes a note taker for the minister. I think that is what went wrong with this. And I think when I wanted to propose it a couple of weeks before or couple of months before to another donor, where I said that let's make a health sector reform, make it more viable, उनका आंसर भी यही था कि वो जो health sector reform unit है, it is not bringing in evidence for the policy makers. वो तो note taker बन चुका है minister का, या कि उसकी speech लिखता है, summary बनाता है, note draft करता है. So the purpose of that health sector, I'm just trying to answer your question.
Yeah, but I didn't ask for a health sector unit. I asked for something that works and not for something that doesn't work.
Yeah, that is something. I mean, that is the political problem. That we make an organization with a different purpose, and this political system comes into it.
Yes. So then I reformulate my question, because I know this, of course. I was even inside that unit at the beginning. I know this. So I reformulate my question: what do you think is necessary to have such an organization which can take care of very complex questions? Because every single question that has been raised here, I bet there is no straightforward answer to this, and yet answers are needed because otherwise you cannot advance and you cannot stop at this level of a development that you have just started. So there must be some mechanism in order to guide this, to put some structure into this. What could it be? That would be my question then.
I cannot give you a solution for that, but you have been longer than me in the health system, and you know that. Let's not talk about health sector reform. Let's talk about PIDE. PIDE, Pakistan Institute of Development Economics, was developed under the Planning Commission with the key objective of doing research. It was a think tank. What has it become now?
The PIDE of Pakistan.
University. I fully agree that if you want me to give a solution, I do not have a solution in my head, which I can just simply jot down and say, this is the right decision.
I just would like to add simply. I'd like to add simply what the system we have in Pakistan. Under this model, we have the policymakers at the secretariat level, for example, in Balochistan. And the program and thematic head is the Director General Health Services. What happens with the Office of the Director General, they are actually supposed to be focusing on program. They have also become a kind of bureaucrats, unfortunately. I believe the actual mandate of the Director General Health Services is supposed to be revived rather than having other entities, health sector reform unit, blah unit, blah unit, blah unit. Because they have got their own directors under them. They've got this HSRU can be placed there. And the Director General Health Services is always a technical person, program person, public health expert, public health policy expert. So I believe this one mechanism, old mechanism already exists, and under a very proper and effective thought it was constructed. Unfortunately, the parallel institutions which we are creating, I'm always against them. Planning cell we have established at the secretariat level, that is doing planning work. We have established health sector reforms unit, though they are working very well. But I believe in sustainability does not lie with. We have to go back to the Office of the Director General Health Services, and they can then provide feedback to the policymakers. Okay, here we need, here we do not need. For example, I just would like to refer to one very recent initiative of the Director General Health Services Office is to go from DHIS 1 to DHIS 2, District Health Information System. The DHIS 1 was monthly data collection, you know it very well. This one is going to be disease surveillance on daily basis. So the surveillance and epidemiological unit they are going to have under DHIS. So I suggest that we have the system. Unfortunately, the system has stopped working. That can be done.
Dr. Sheraz, do you have comments on this?
Yeah, thank you very much. So I'll just add to it. And what Franz has asked is really a pertinent question. We usually talk about the money part, but not about the risk part or the disease part and stratification within the risk part. And since I'm one of the original sinners, I think my colleagues at BHCP wouldn't mind it that the benefit package we have across Pakistan, it is ad hoc. Right? If I ask you, are we covering the most prevalent diseases because they have disease burden? The answer would be no, we are covering some very remote diseases which are not very often occurring. Then it is ad hoc. If I ask you, are we covering only the diseases that have catastrophic effects? No, we are covering the removal of the mole, which would cost probably a few hundred or a few thousand rupees. Right? And building on this thing, I went with my sister to a Panel hospital and she had a horsewise. And horsewise is one of the first signs or symptoms of laryngeal carcinoma. And the surgeon said she is having 2 polyps on her vocal cord. I went to the State Life counter. This is the scene I see. She is covered and polypectomy is required. He said, well, we are covering only nasal polyp and rectal polyp. Laryngeal polyp is not there. Now the question is this a systematic classification of the benefit package? On a systematic classification, everything on the airway or the respiratory system should be covered. By that account, nasal polyp and laryngeal polyp both are part of the respiratory system. Then why laryngeal polyp is not covered? On the other hand, if polyps are covered, then a polyp anywhere is a polyp everywhere. That should be covered. I think, France, that the need of the hour is for the program to ask policy questions. You know, on what basis am I going to define the benefit package? Is it prevalence? Is it mortality? Is it the cost impact? And once you ask those questions, then you can refer those questions to the right sections within the government, and we do not have to make new organizations for that. One wrong thing that happened with our program in KP, they made a law and annexed this list of, which I call a wish list of 1,200 procedures, that this is the basic benefit package. And if anything more is required, we will add to it. And my question was, rather than having a fixed benefit package, in the law you should define the principles for the initial benefit package and the principles for an ongoing updating of the benefit package.
Thank you, Sheraz. Sir.
I just would like, because from Dr. Saab's question, I've had another insight as well. Here in this hall, we are revolving, our thoughts are revolving around the policy paradigm of the healthcare card system, insurance system. I just would like, this is a public health debate, I think DG should work on it to have another dialogue on. Actually, in Pakistan, the irony with the biomedical system we have had in Pakistan is that we have been focusing on a curative model to be treating the patients and ignoring the other three pillars of the healthcare system. This is another addition to it, to the biomedical model which we have had since 1947. So I believe, okay, other than the health card, of course health card is very much need of the day, it's not going to have impact on eradicating diseases, because for eradication of the diseases, you have to have the preventive and promotional models to eradicate and to control and to manage and to have the real-time impact. This one is going to help the policymakers to be addressing the hue and cry, daily hue and cry, the patients are there and we are treating. So we have to have other dialogues as well, I believe.
Thank you, sir. With due apologies, it is a burden to announce the end of this segment. I would like to thank all the panelists, and I would like to ask you to remain seated.